Thank you very much for the invitation to speak, and also congratulations on what sounds like a wonderful conference, in that it looks like you've attracted hundreds of people with multiple partners. So that's really fantastic. And what I'm going to talk about today is tackling health inequities in an era of poly-crises, which I think most people would agree we're living in. In Australia now, it's customary to acknowledge the country that we're speaking from. And I am speaking from the lands of the Kaurna people. That's the colonised name is Adelaide. And I'd like to pay respects to the elders past, present and emerging, and also respect and admire their resistance through the processes of colonisation that I will be talking about in a bit. I think I've got about 25 minutes to talk today, and I'm going to think about the poly-crisis we face, then think about health equity and power. And I was very pleased that Alice introduced the issue of power in her talk. And I'll end with some signs of hope, so I don't leave you feeling too depressed. Just first, when people think about what should we do about health inequities, often they jump to the sort of what I've called the tip of the iceberg, which is often lifestyle risk factors, and say, well, if only people would stop drinking or smoking or live a healthier lifestyle or walk more. And then, of course, we got people saying, well, we need the social determinants of health, and that's really important. We've just heard about homeless people. But that's in terms of the conditions of daily living, the housing, unemployment, social support, whether you're in a polluted environment, what your work's like, and so on. But I've increasingly, when I think about health inequities, interested in the bottom of the triangle, which is the sort of economic and social structures that we live in, and thinking of issues of power and wealth distribution, and of course gender and class and other sort of intersectional issues. And really, I think that if you intervene at the tip of the iceberg, you can have some impact, but you're more likely to increase health inequities because better off people are in a stronger place to change their lifestyle. Probably you'll make more impact with daily living conditions, but I really think we need to start thinking very intersectorally, but thinking about some of our basic structures that reproduce inequalities. And as I say, we're now, I think, in an era of poly-crises. If we start in the top right-hand corner, many countries around the world are facing a financial and cost of living crisis. It sounds like you are in Ireland from the introductory comments. In Australia, we have inflation. We've got wages falling behind the profits increases. This is leading to a lot of social crisis, whether it's isolation, less solidarity, less community spirit, and so on. And also, of course, fundamentalism, the threat of terrorism, racism, and hate speech. Much political leadership around the world is really following a neoliberal agenda, which is more pro-profit than health. There's an increasingly unstable political class, and we only have to look across the water from the point of view to the UK with 3 prime ministers in a very short time. There's been a massive privatisation of public assets in many countries, the rise of populist leaders, which in itself I think reflects a declining trust. There's growing conflict around the war, first of all, Ukraine, the Sudan, Ethiopia, there was a terrible civil war. And of course, in the last month, Gaza. We've watched Gaza being bombed. We've watched the impact of terrorism in Israel. And then underpinning all this, there's an ecological and climate crisis, which is seeing in Australia, we are having increasing disasters, floods, fires, droughts. There is a lot of excessive extraction, particularly of fossil fuels. Indigenous people really are very passionate about the destruction of their country. Pandemics are resulting from some of the changing climate, and of course an unsustainable food supply. So those are some of the poly-crises that we're facing. The important bit, I think, is the centre of that. What is the heart of all this? And at the heart of many of these problems is an unfair global economic and political system that both creates growing inequities, both within countries, but also between countries. Much of it's based on an extractive capitalism. I'll talk about the concentration of power in the hands of transnational corporations, the concentration of wealth, the fact that there's huge overconsumption for some people and underconsumption for most other people. The focus on profits that I've talked about, and of course, exploitation of the environment. So together with my colleague, who many of you may know, Sharon Friel, as I know she worked in Ireland for some time, Sharon and I headed a Centre for Research Excellence on Health Equity. And one of the pieces of work that we did as part of that was to come up with this health equity power framework, because we were looking at policies and how policies affected the social determinants of health. But in every case study, we found that we really needed to look at the types of power at work, what the form of power was, how power was distributed between the state, the market, and civil society, different levels of power, global, national, and local, whether spaces are open for everybody, or they're closed, or they're invited, or they're claimed by claim holders. And those power inequities were what very much feed into health inequities. So I'll take that. And I haven't got time really, that's a really big topic, but what I thought I'd do today is look at some of the ideational power blocking issues that are blocking health inequities. So I do want to look at neoliberalism and its twin, individualism, behaviorism, victim blaming, and the so-called lifestyle drift. I want to think about a bit of the importance of political will for health equity, the issue of corporate and elite power, a little bit at medical power, and then at some colonial legacies. So I think we had a great example of a politician pursuing an individualist line in the UK minister, Sula Braverman, who said just a few weeks ago that rough sleeping was a lifestyle choice. In other words, it's the problem of the homeless people. It's not the problem of society hasn't provided enough affordable homes, but it's the problem of homeless people themselves. And I've also included a quote from an Australian Prime Minister when he was Health Minister. And you can see he said, "No one is in charge of what goes into my mouth except me. No one is in charge of what goes into kids' mouths except their parents." And then he goes on to say, if their parents are foolish enough to feed their children on a diet of Coca-Cola and lollies, well, they should lift their game and lift it urgently. So you can see if a minister has that viewpoint, then if you think about my health equity triangle, they're likely to focus only on lifestyle issues at the top of that triangle. And those views strongly support the idea that the government and market have no responsibility. And that in itself really dramatically reduces political will for action on health equity. Now, in the study I told you about that we did in our Centre for Health Excellence, we looked at 8 case studies that are listed in the top box of determinants of health. And the one in green, the paid parental leave, is the only one where we felt there had been real moves towards equity. In the ones in orange, primary health care, closing the gap between Indigenous and non-Indigenous Australians' life expectancy, an urban planning project, and a broadband network. We felt there'd been a very mixed results. And when we looked at a factory closure and a trade agreement and an intervention in the Northern Territory, which targeted Aboriginal people there was actually a negative impact of the policy. And what we looked at through those 8 case studies, we interviewed about 180 different policy makers in each of those case studies. And we really found that the extent of political will really depended on how strong the path dependency was in favour of either equity or inequity, the electoral concerns, which were asking the question of whether there were sympathetic political forces that were committed to fairness. And we also looked at the kind of framing of issues. And if you want to gain political will for health equity, it's very important to think about that framing and whether you can use other frames other than just straight, this is good for health. You might be able to say, well, this is good for employment, as they did in the case of the parental leave one. And it's also about asking whether elites can be challenged or what are they protecting. And also we found that civil society lobbying can be really important in favour of equitable policies. So that we really broke down what is political will and saw it as absolutely vital in all these case studies. And one of the things our researchers increasingly pointed to is the issue of corporate power. And I was first alerted to that in the mid-1990s when I read this book, When Corporations Rule the World. And in that, David Corton said transnational corporations are ruling the world like feudal overlords. And he noted that they have an obsession with economic growth and with unhealthy consumption and extraction. And he also made the point in this later book that focus on economic growth really ignores the fact that all of us as people are part of an interconnected web of life, and we are dependent for each other upon our well-being, and also dependent on a world that stays sustainable. And I think since David's written his books, his sort of prophecy of corporations ruling the world has really come true. We certainly saw during COVID, in just about every country on which there is appropriate data, that inequities were increasing, and that people who were either by the nature of their racial background or their economic background were the people who were most likely to die from COVID. But we also saw an increase in economic inequities. And Antonio Guterres, who's one of my heroes, who's currently the UN Secretary General, said the myth that we're all in the same boat while we're all floating on the same sea, it's clear that some are in super yachts while others are clinging to the drifting debris. And in terms of the conference title, this situation is leaving more and more people behind. They're just being left behind. And if you look at the biggest countries in the world by their market capitalization, the biggest corporations, you can see that they're really primarily a mix of tech and fossil fuels and sort of new technologies and pharmaceutical. But if we take Apple, which is the largest corporation in the world, what you see there on the left is all those countries have a lower GDP than the capital marketization of Apple. So that just gives you an idea of how powerful corporations have become. And I think now of the biggest 100 economies in the world, now about 68% of corporations, 68 of them are corporations. And the other thing that's really happened, and this relates to the sort of upward growth of wealth, is that compared to the early 1970s, CEOs now make nearly 400 times as much as the typical worker. And of course, that was far lower in 1970. So that's been a massive change. Rather than leaving no one behind, what we've seen is the top has left everybody behind, if you like. And just as one further example, just thinking about the Amazon CEO, one of the biggest countries in the world, a lot of their services are offered to government, so they get lots of public money, but their CEO now earns nearly 6,500 times the company's median pay. And that was approved by the shareholders. So that's massive. And along with that, if we look at the sort of behavior, if we take a lifestyle lens for the richest billionaires, then they're much more likely to be responsible for greenhouse emissions. In other words, for creating the climate problem that they can probably afford to avoid in their lifestyle, but is being imposed on particularly a lot of poor countries and poor people in most countries. So this analysis in the Guardian reported the other day is that billionaires emit 1 million times more carbon than the average person. So you can see how this is feeding into inequities in all sorts of ways, including health inequities. And that corporate power it hasn't just happened, it's actually come about by a lot of lobbying, a lot of shifting of ideologies, and a lot of advocacy. And this is just one example of an analysis of the US Chamber of Commerce, but you can see this for a lot of business advocacy groups in different countries around the world, that in fact the US Chamber was a well-funded influence machine seeking to build an economy where government becomes a tool of big business. And Elisa Katz felt that they'd been successful in doing that. And similarly, this analysis talked about the ways in which billionaires had fueled the rise of a radical right that really was very anti-regulation, was very pro-free market policies, was framing discourses in their favour, and, for instance, supported political candidates who then cut funding to the Environmental Protection Agency. And those are the sorts of ideologies that will also underpin the idea that it's actually lifestyle that's the problem. That's why people who have less money in their lives, that they don't adopt lifestyles that are likely to promote their health, rather than looking at all those broader factors. Of course, the protection against that is public accountability. And I just had a look at Ireland, just in terms of your public accountability mechanisms, and note that you do quite well in terms of freedom of information and in terms of political financing, but there are areas for improvement of conflict of interest, freedom of, public procurement, how open they are, and financial disclosure. But it's this kind of accountability that the corporate world works very hard to avoid and encourage governments to drop those. And then the other thing that my research groups become interested in is looking at the influence of industry-funded research and looking at the ways in which that really focuses on products with commercial application rather than public health topics. So, medical research is biased to rich country issues. A lot of money in research now goes to the armament industry and the fossil fuels. And there's much less about how can we strengthen the public service, how can we have public policies that result in good health for everybody. They also fund research to detract from the harms of their products, and we've seen that with tobacco, but also with alcohol and cancer. And I don't know if it's a big issue in Australia at the moment is vaping. And there's been a lot of effort to try and detract from the harms of vaping. The pharmaceutical industry floods scientific literature with research which maximises the benefits and minimises the harms of their products. And it means a lot of the research in pharmaceutical industry is going on drugs that tend to have high cost and aren't tackling the big issues in the world, such as diarrheal diseases and so on, and infections. There's also plenty of evidence that data is suppressed by a lot of corporate research, that if it doesn't support the view of the industry that's funding the research, then it is suppressed. And generally in our universities, there's a trend, Barrow claims, and I think she's probably right, of privileging business-related research over critical social justice research, which would include a lot of public health research. So for me, then, when we think about reducing, how do we tackle health inequities, we really have to look at the commercial determinants of health. And together with colleagues, in a paper we published earlier this year, we defined that as the systems, practices and pathways through which commercial actors drive health inequity. And there we came up with a conceptual model of the commercial determinants of health. But if you look in the circles, within the circles on the top left-hand corner, you'll see that it names those political practices, those scientific practices, marketing practices, which how you market tobacco or alcohol and so on, supply chain issues, labour and employment practices, and financial practices. And all those things are influencing these social determinants of health and ultimately, in the end, affect how ill health and health inequities are created. And so what we're really looking at in that sort of research on the commercial determinants of health is how that system works to actually create health inequities. Now, the next issue I want to look at briefly is medical power. This isn't new to a public health audience, but health departments are really illness care departments. There's a strong discursive power in terms of curing illness, and so so less kind of health promotion work and a very medically dominated system. Some research has begun to look at so-called right care and futile care at the end of life, but they're more named rather than action, even though a lot of money is spent there. There are strong links between medicine and corporations, and increasingly health corporations or people who provide health services are infiltrating publicly provided services around the world, whether it's the NHS or in newly developing markets like India and the Philippines. And of course, health promotion and disease prevention are usually the poor cousins of treatment and clinical and surgical interventions. So medical power is quite invisible but quite strong, and it does tend to keep a focus off health inequities. Some of work we did on comprehensive primary health care under sort of neoliberal governments, we found it was very hard to implement comprehensive primary health care because narrow managerial reforms really reduced the scope of practice for primary health care. We found budget pressures usually found health promotion and disease prevention were cut disproportionately. Competitive tendering tends to put a focus on outputs rather than health outcomes. And in the state of South Australia, which we were studying, community health services transformed into intermediate care centres for chronic disease. And it was very often those community health services that were providing services to those people who had low income, were Aboriginal, were migrants, and found the mainstream services much harder to use. Now, in South Australia, we've certainly had a successful health in all policies project to some extent. It has been high profile for a period, but equity was really sidelined in health in all policies. And while we found there were some process changes, like some growing trust, some appreciation of the sort of broad health impact of non-health sectors, and it certainly stopped lifestyle drift, there were constant conflicts between the health and economic agenda of the government. And in fact, the Hyatt budget was only 0.01% of the total health budget. But nonetheless, it has survived through several reorganisations and now sits in a department called Wellbeing SA. Now, the last thing I want to look at before I hope to end and be a bit more hopeful is just looking at the legacy of extractive colonialism and capitalism. And I found that the sort of Britain's blueprint for colonialism was made in Ireland. So as a nation, you're not new to colonialism. You've experienced it for many, many decades. But that was kind of the colonial tactics that then spread around the world and certainly came to Australia. And in Australia, that led from the sort of early part of the 20th century to the 1970s, that children were forcibly removed from their families as a result of various government policies. And that has resulted in there being a significant gap between Aboriginal and non-Aboriginal people in Australia. It used to be much larger. It used to be estimated about 15 years, and it now is about between 8 or 9 years. The data's not brilliant either. But this I'd just like to show you as an example of how the whole sort of structure and institutional and moral and expert power of colonialism was used to justify removing so-called half-caste children from the home. And here you can see that the person's marked saying that I'd like the little girl in the centre of the group, but if she's taken, then I'm happy to have any of the others so long as they're strong, which from that you can see that they're going to be used for labour. So that history of colonialism is still powerfully affecting Aboriginal people's health today. And although we have a closing the gap strategy, most of those targets are not on track, and we have had some narrowing in this century, but not as much as there should be. But our very best response are Aboriginal community-controlled health services, which are able to respond to the needs of their community simply because they are governed by community members on their board of management. And we've also done some work on culturally safe policy, just as health services have to be culturally safe. We've looked at the ways in which policy itself needs to be culturally safe by stressing decolonisation as an overarching issue, by considering power differentials, by developing policy in a reflexive way that's very regardful of Indigenous people, and in fact of anybody really. These are really policies for health equity, even though we had an Aboriginal lens while we looked at that. And they really should involve a dialogue with people who are going to be the recipients of the policy. So I think most of you know what health equity would require. It does need a redistribution of health and income. We do need economic and social security across the lifestyle. We need to redress those inequities that have been associated with colonial expansionism and extractive capitalism. Education is vital, freedom from discrimination, fair and decent employment for everybody, urban, rural and food environments that support healthy living, and of course an accessible, equitable and affordable health system. But you can see that each of those requires challenging ideational and other sources of power. So I increasingly think that health equity, most importantly, needs to be an issue for treasuries and as part of fiscal policy. This would involve much more progressive taxation. A financial transaction tax would yield a lot of money from a part of the economy that is not that productive. Also, a global tax on capital, closing loopholes for transnational corporations and the mega rich, because it's only if you do that do public sectors have the money to provide those social determinants of health that we know will reduce inequities. And I think along with that, we need a campaign to argue for the public good value of tax. You can see a media release here from the South Australian Council of Social Services, where they argued how important taxes were and had the slogan, without taxes, vital services disappear. And I also think we need to envisage different ways of transforming that economic order I looked at earlier, whether it's a steady state economy, a no growth economy, a zero carbon, a well-being economy, encouraging different forms like cooperatives, but that actually puts people needs at the center and sees part of that the reduction of equity. And you know, I always use this equity nutcracker I developed with a cartoonist, Simon Kneeburn, and community action is going to be vital to sort of cracking health equity, because it's not going to work with just one arm of the lever. You need both arms of the lever to create health equity. A lot of my hope is in social movements, and particularly young people. This is just an example of how they're demanding change on the climate system. And I do a lot of activism with the People's Health Movement, because I think that that kind of movement is absolutely essential for change in the world, to bring about that bottom lever of the nutcracker. And this is just the vision that the People's Health Movement developed in 2000 when they held our first People's Health Assembly. And we very much stressed ecologically sustainable development, but also diversity of life, reflecting the fact that the planet only has so much holding capacity, and a world that, I really like this phrase, that enables the flowering of people's talents and abilities to enrich each other, a world in which people's voices guide the decisions that shape their lives. So for me, it's about how do we get to that world, rather than a world, in David Corton's word, when corporations rule the world. And just finally, just to give you a plug, in April in Mar del Plata in Argentina, we're holding the 5th People's Health Assembly, where we will be looking at the Health for All and Struggle for Buen Vivir, which is a South American concept of the good life, but it involves sort of life for everybody and the planet and people. So once again, thank you very much for asking me to talk. It's been a great honour, and I hope you're going to have fantastic discussions today about how you can reduce inequities. Thank you.